Welcome to the VJHemOnc Podcast. In today's episode, we're diving into one of the more aggressive and challenging manifestations of multiple myeloma, extramedullary disease, or EMD. We'll be sharing the latest insights from leading experts on how EMD presents, how it's managed, and what we're learning about its complex biology. Plus, we'll explore emerging treatment strategies and clinical trials, including the RedirecTT-1 trial. Let's begin with Meral Beksac, who outlines the typical clinical features of extramedullary myeloma and current approaches to management.
Extramedullary plasmacytoma was initially thought to be a rare feature of multiple myeloma, but now with the introduction of more advanced imaging techniques and wider use of PET-CT, now we're recognizing EMD at diagnosis within a 5 to 10% of patients, and this incidence is increasing with the relapses, and at later phases of more advanced patients, then the incidence is even higher. Initially, extramedullary disease, if it happens as a single feature, so what we call as a solitary plasmacytoma, was regarded as a disease which is separate from multiple myeloma and was treated as a unique approach with surgery and radiotherapy without a systemic therapy. But with newer tools, if we measure in deep the M protein in the blood or in urine with free light chains, it's possible that we may find dissemination of the disease, and that's a sign that we need to give a systemic therapy. And if a patient is diagnosed with extramedullary disease, it's unfortunately a poor prognostic feature. For this purpose, we need to give our best available treatment possible, and that includes usually the quadruplets, and we need to give PI-based regimen. In plus, one may consider using such as a lymphoma type of polychemotherapy, and this is usually more recommended for patients who are presenting with secondary extramedullary plasmacytoma. And for a newly diagnosed patient presenting with an extramedullary plasmacytoma, after the induction regimens, high-dose melphalan with the help of stem cell transplant, and followed by maintenance phase, which includes a PI and an IMiD, is the recommended approach. But any time during the course of this disease, we have to evaluate the response, not only in the marrow, the traditional hematological response assessment, but we also need to use the imaging response criteria, and that will allow us to look at the response in the EMD carefully, with metabolic response, with complete response being the aimed final endpoint. So the presentation of the extramedullary disease may differ. The paraosseous spread from the bone, this really doesn't make a major impact on the course of the disease. This is called the paraskeletal or paraosseous form. The real extramedullary disease are the ones which are not in the proximity of the bone or bone marrow, but they occur such as in the skin, in organs such as the liver, or in lymph nodes, for instance, the lungs, or even in the central nervous system. So the symptoms, the presentations are defined by the localization. Sometimes in the skin, you can notice very bizarre type of infiltrations, and which can grow up, and in lymph nodes may enlarge, and the intra-abdominal lesions may have a compression on, for instance, the urinary tract, and also on the lymphatic system, which causes a swelling on the legs. So there is a very bizarre presentation with different symptomatology.
Next, we shift our focus to the biology of EMD, an area that remains incompletely understood. Mehmet Samur and Saurabh Zanwar join us to discuss recent advances in this field. Dr. Samur highlights key advances and unanswered questions, followed by Dr. Zanwar, who discusses a study investigating the genomic characteristics of EMD.
So EMD is one of the fields that we really understand much better than what we know today, is mainly because with the developments in immunotherapies, EMD is one space where we keep seeing patients are relapsing with very little disease or no disease in their bone marrow, but the disease relapses from these extramedullary sites. There has been presentations and papers recently at ASH and then in some journals that we have seen showing EMD biology compared to newly diagnosed disease biology. And what consistently shown by those presenters was that the EMD sites often show features that goes more similar to high-risk disease that we have in bone marrow. There are still unanswered questions, though, like whether or not the EMD microenvironment is very similar to bone marrow microenvironment. There are people and research groups still focusing on these questions, comparing EMD sites with the marrow to understand if they have a similar microenvironment. There are still questions whether or not the EMD is a reflection of high-risk disease or it's like still a very diverse disease side similar to bone marrows. I think compared to a few years ago, we have made some progress, but we are still lacking a lot of information in this space. It is because most of the researchers we have today are focusing on directly the bone marrow, where it is the origin of this disease. But as we make progress, as we are adding more single-cell technologies, adding more bulk sequencing to what is available, I think we are going to learn more. There are still a lot of questions that has not been answered specific to EMD today.
In our study, we sequenced 18 extramedullary tumors and 20 bone marrow aspirates collected from patients that had extramedullary disease at the time point of development of extramedullary disease. And 6 of these had paired bone marrow samples. What we noted right off the bat was extramedullary disease is highly enriched in MAP kinase pathway alterations. 94% of extramedullary samples had one or more MAP kinase pathway alterations, including the common driver mutations in RAS, RAF, and the RAS, RAF genes. Compared to that, bone marrow aspirates are about 60% of those samples harboring a MAP kinase pathway alteration, and this difference was statistically significant. What we also observed was these mutations in the NRAS, KRAS, and BRAF genes are frequently clonal in extramedullary disease compared to bone marrow aspirates. Another important finding from our paper was looking at the genomic complexity in terms of copy number alterations, and EMDs seem to be enriched in 1q gains and amplifications, and the frequency and amplitude was higher than what was noted in the bone marrow samples. An interesting thing that we noted was there were frequent biallelic alterations in the tumor suppressor gene MAX, which acts as a binding partner for MEK and regulates the role of MEK. These were observed in 22% of the EMD samples. This is a much higher frequency than what has been previously published in myeloma literature. Also, biallelic alterations in CDKN2C, an important tumor suppressor gene located on 1p chromosome, was noted in 17% of the EMD samples. Overall, we noted that extramedullary samples have a much higher tumor mutational burden as well compared to bone marrow aspirates. In general, it shows that these tumors are genomically complex and quite heterogeneous.
We will now turn our focus to the RedirecT-1 trial, investigating the safety and efficacy of talquetamab and teclistamab in relapsed refractory multiple myeloma with EMD. Shaji Kumar now joins us to share findings from this study.
So extramedullary disease is a real problem in patients with multiple myeloma. Patients who develop true extramedullary disease where the plasmacytoma is developing not in contiguity with the bone lesions. It could be in different organs, soft tissue, but these are truly extramedullary. And these, whether they are diagnosed at the time of initial myeloma diagnosis or they develop subsequently at the time of relapse, is usually associated with very poor outcomes. In fact, many of the treatments, including some of the novel immunotherapies like CAR-T and bispecific antibodies used by itself, often give responses higher than what we have seen in the past, but they often tend not to be very durable, as these lesions, which are biologically very complex, often breaks through these treatments. So the RedirecTT-1 trial, the phase 1 original study, had looked at the safety and efficacy of talquetamab and teclistamab used in combination in patients with relapsed myeloma. So among those 94 patients, there were 18 patients who had extramedullary disease and had responses that we had not previously observed, with a response rate of about 61% among that 18 patients. So that led to the interest in trying to explore the combination of TEC and TAL in patients with extramedullary disease. So this was a phase 2 trial that was a cohort within the RedirecTT-1 trial that only enrolled patients with true extramedullary disease. So they had to have at least one lesion that was non-contiguous to bone, at least 2 centimeters in size. But these patients did not need to have secretory or measurable disease by paraprotein that we typically require for many of the myeloma studies. So in fact, almost 40% of the patients did not have any measurable disease by protein in this particular cohort. So this was truly patients with an unmet need, both in terms of the fact that they had extramedullary disease, but also the fact that they are often not included in clinical trials for the lack of paraprotein. So we enrolled a total of 90 patients on this trial. The profile is very similar to that what we typically see in the context of relapsed disease. Most of these patients, all these patients are triple class exposed. Many of them were penta-drug exposed. Almost 30% of these patients had seen a prior bispecific antibody or a BCMA-targeted therapy or a CAR-T. And most importantly, these patients their responses were assessed very uniformly using a central imaging with PET or MRI or both. So these patients were treated with a step-up dosing. There were 3 step-up dosing for teclistamab as well as talquetamab, and then patients would get the full dose. And the full dose was given every 2 weeks for 4 cycles, and then patients could go to every month if they had a VGPR. Or after 6 cycles, everybody could go to once a month. With this approach, we saw that the overall response rate was about 80% in this patient population with extramedullary disease. The median progression-free survival was about 15.4 months for the entire cohort, and the median duration of response was a little over 13 months. Again, these, the follow-up is only about 13 to 14 months at this point in time. But what we saw was that the majority of the patients, almost 2/3 of them, still continue on therapy at this point at the latest data cutoff. And the overall discontinuation rate was fairly low because of adverse events. In terms of the adverse events itself, again, the toxicity profile was no different than what we have seen with bispecific antibodies in general, and particularly with teclistamab and talquetamab. So we did see common hematological toxicity, very similar to what we have seen with bispecific antibodies in general. Of particular importance is the fact that we did not see any new toxicities associated with the combination. We did see cytokine release syndrome in about 70 to 80% of the patients, mostly grade 1 or 2. We did see ICANS in about 12%, mostly grade 1 or 2, and most of these happened during the step-up dosing and with the first dose. And there were 10 deaths on treatment or in the trial. 5 of them were related to infections. At least 3 or 4 of them were in the context of hypergammaglobulinemia or disease progression. And we also had 5 non-infectious deaths, that only 1 of them happened in the context of ICANS and was considered related to therapy. So all in all, the results suggest that the combination of teclistamab and talquetamab is providing a response rate, a depth of response, and a durability of response that we typically have not seen in the context of extramedullary disease, and certainly seems to reflect a step forward. Obviously, how will this play out in the clinical practice, and what will a trispecific antibody like the one that was presented at ASCO be an alternate approach for these patients? But nevertheless, I think this is another set of evidence showing that we are making progress in this disease.
Finally, we go back to Saurabh Zanwar, who shares his final thoughts on challenges and opportunities in this field.
One of the challenges here is that even novel therapies, immune effector therapies like CAR-T therapy, extramedullary disease continues to be a marker of poor prognosis. When we looked at a large cohort of patients treated with ide-cel, over 350 patients, about 1/4 of them had true extramedullary disease. The median PFS there was 5 months. Recent data from cilta-cel demonstrated that PFS to be a little bit better at around 7 to 8 months, but still pretty dismal outcomes compared to patients when they don't have extramedullary disease. There has been encouraging data. The teclistamab and talquetamab combination seems to demonstrate very high overall response rates even in patients with extramedullary disease, and these responses seem to be durable. So maybe combination strategies with immune effector therapies is the way going forward in these tumors. But more therapies are needed, more targeted therapies and rational combinations are needed. From our data, potentially exploring a MEK inhibitor in combination with some other strategies could be important. If we can somehow uncouple the MEK and MAX interaction with small molecular inhibitors, that could be an important therapeutic avenue to explore as well. And we also noted some increased EP300 alterations, and there are small molecular inhibitors in clinical trials that are out there which could be explored specifically in extramedullary disease as well.
That wraps up today's episode on extramedullary disease in multiple myeloma. We hope these expert insights help keep you informed on this evolving area of research. For more HemOnc updates, follow us on X at VJHemOnc and subscribe to our VJHemOnc podcast on Spotify, Apple Podcasts, or Podbean. Thanks for listening, and we'll see you in the next episode.